Hello, Matt. Welcome into our AFib A-Z talk tonight. I'm
Hello.
so excited.
I'm excited.
So, Matt, tell us kind of how tonight's going to flow so everybody knows.
Yeah, so this is me, Matt. I'm with Scope Education. This is Jen with Cardiology Made Easy. So basically what we're going to kind of do is we're going to talk about AFib and when it comes to relation to talking about it with a patient and as providers. We're going to go over some treatment plans, kind of the causes of it. Like I said, we're going to have a little case with Jen. That's going to be super exciting, and we can all contribute along with that. But without further ado, are you ready to start, Jen?
Yeah, let's kick
Okay.
it off, Matt.
So, as I said, my name is Matt with Scope Education. I'm proud to announce that CardioVisual and I are creating and having a collaboration where we're going to have a whole YouTube series on CardioVisual on YouTube, along with Medical Visual. And so, without further ado, let's talk about a little bit about AFib. Boston. Okay, so you're up there with what's his name? My Heart MD.
Yeah.
So, what is AFib? So AFib, as most of us are probably medical providers, we all kind of know what AFib is. You kind of look at it and you're like, all right, irregular, no P waves. That's going to be your AFib. But how do we differentiate that with like your AFib and A-flutter and your SVT? So first off, SVT is just some big umbrella term. When I was a paramedic, I loved saying SVT because that meant anything that's fast, that's kind of going up near the atria region, that's going to be your SVT. It was really simple, easy for me. However, when you start getting more into medicine, SVT, like I said, encompasses a whole slew of things. And this includes like your AV nodal reentry tachycardias, atrioventricular reentry tachycardias, and so on and so forth. So one of the ways that I can kind of differentiate between AFib and your AVNRT or AVRT is just look at the regularities. AFib is going to be more irregular, and those are going to be more irregular. With your A-flutter, though, it's mostly, it can be either variable or, irregular. So it's kind of hit or miss. When it's really regular, it's going to be obviously not your AFib. When it's irregular, you're going to have those variable conduction ratios. So it can go bounce between a 4-to-1, 5-to-1, 1-to-1, 2-to-1, and it just keeps making it become irregular. So one of the ways that I do is you can actually use something called a Lewis lead. You basically just reposition some of your leads around, and I always look around on things, and you can actually see it there. Sawtooth, looking for your classical sawtooth pattern as well. One of the best leads to actually see your atrial activity is going to be V1. So V1 is kind of like your money lead. So I always look at V1 for any kind of atrial activity, such as whether it's the sawtooth pattern or if it's just the fibrillatory waves as well. So let's talk a little bit more about AFib. So RVR. So RVR is rapid ventricular response or rapid ventricular rate. We like to make everything a little bit more complicated in medicine. Instead of just saying fast AFib, we just like to call it RVR, just for funsies, right? That's all that kind of means. Is just that it means it has a fast rate. But what happens if you have? They actually did some studies, and some of the issues that they saw patients with AFib is that they're more likely to actually have an MI because of all the co-exciting factors, such as like atherosclerosis or hypertension, your diabetes and stuff like that can actually make it worse. And patients with LVH and AFib actually have worse outcomes. So I'm trying to read some stuff. Is it shockable? Anything can be shockable. Most things can be shockable. So I guess that kind of wraps it up for my part of it. I'm interested to see what kind of cases that Jen has.
Yeah, Matt. So, I think one of the challenges for us as providers is, first of all, spotting the AFib. So this is great that you're going to do a series on all things, including AFib, so people can get more comfortable with the rhythm. But basically, we go back to the nuts and bolts when identifying it, right? So we want to know that it is irregularly irregular, and then we're looking for lack of P waves. So just to bring up a case that I recently had, it'll illustrate kind of a couple of the causes that I know, Matt, you want to highlight, but also it talks about how to look at someone with palpitations. Okay, so this is a great case of a 41-year-old male, and you can see he's quite overweight, which, as Matt's going to talk about, is a risk factor. And what's interesting about the guidelines, just to sidestep for a second, is they've now, in 2023, they've now updated the guidelines to talk about, with our patients, the risks and try to work on them and modify them. So going back to that patient that we just saw, that 41-year-old, looking at his body habitus, Matt, what do you think is going to be a driver if he has AFib?
If he's got AFib, it's going to be probably his obesity, hypertension, possibly a little diabetes.
Yeah, absolutely. And so one of the things, like you were talking about, Matt, LVH, left ventricular hypertrophy, is probably also going to be at play here as well, because the heart's a muscle, it gets thicker and bigger, especially if you have a lot of weight to push the blood around, right? So the heart is just going to get thicker. So in this case, he's 41 with palpitations and has frequent urination. So we're going to see his EKG in just a minute, but think about, oh, Matt's already put it in the chat. Matt's thinking about obstructive sleep apnea. So why did you say that, Matt? What was your clue that really tuned you into that?
The large habitus, I know that those kinds of patients, whenever they are laying back like this, they'll have just obstructive sleep apnea. It's going to increase the pressure around their heart, and that can enlarge your atria, and that can cause your AFib.
Absolutely. And there's a question in the chat. What is OSA? Thank you for answering it. Obstructive sleep apnea. Yes, Allison, thank you for chiming in on that as well. So going back to the frequent urination, that's also something you can see with patients with sleep apnea. And sleep apnea is a risk for AFib, especially in someone who's 41. So another thing I might think about with him, because we're going to see his EKG in just a second, would be, does he drink alcohol? Because that can also be a driver for AFib. And I would want to ask him about, does he consume energy drinks? Those are all risk factors to go into AFib. So his EKG, as shown here, we're going to look through that in a second. Here it is. So the first thing I want you guys to notice, just looking at the EKG, right? I always look at EKGs. Are they big sick or a little sick? What I mean by that is big sick. Are they STEMI? Are they asystole? Are they VTAC? Are they VFib? If they are, that's going to be, we don't do our 10-step system. We're going to get them where they need to go. But this patient, he has a fairly normal rate. But the one thing I want to point out to you is there's a long lead strip at the bottom, which is actually V1 pulled out. So when you look at it, there's a lack of P waves, but it's also, what do you notice about it, Matt? Is it regular or irregular?
It is irregular.
Okay, awesome.
Irregular.
Yeah, that's the key right there. Irregular, irregular. And there's an echo tech who says, this is very interesting. So as an echo tech, I just want to make this pertinent to you, because what we're always asking you, and we're going to do on this gentleman, is to comment on two things. Well, three things, right? Actually four. Let's talk about it. So we're looking at the atrial size, because that's going to help us determine as a clinician what we're going to do with you. Are you a candidate for ablation? And if you have at least moderate to severe enlargement of your atrium, you're probably not going to be a good candidate, although sometimes we will still try an ablation, because ablation now has a higher recommendation in the guidelines. The other thing we're going to be asking you as the echo tech is, do they have any right ventricular enlargement? Okay, hey Kevin, nice to see you, paramedic on with us. So if they have right ventricular enlargement, that is really common with sleep apnea as well. We also want to know the ejection fraction. So that's the amount of squeeze, because that's going to determine also, in addition to treating his AFib, what are we going to do about it medication-wise? And then lastly, we also want to think about another potential driver of AFib, and that's called ischemic substrate. So what that means is that AFib can sometimes be driven by ischemia. So at some point in the workup, they're going to get a stress test. So SOLA, yes, most centers use 55 as normal. Some centers use 60. But we're going down to see his stress test now. So luckily we're ruling out ischemic substrate, but wait, are we? His ejection fraction is depressed, okay, which we notice. And we're worrying about ischemic substrate with him because this is an abnormal stress test. So if you go back to his echo, which I think is the last slide that we have for you tonight, if you go back to the echo, what you'll see is there's a discrepancy. So I want to talk about that, especially for providers that deal with these two tests and how to make sense of them. So first of all, we're looking to see, and he has only mild left ventricular hypertrophy. Now, Matt probably could tell you that he predicted that, because what was missing on the EKG, Matt, that would have said he had LVH?
That high voltage, you can use a ton of different kind of stuff. I'm a very simplistic person. I don't like adding. So I like to just say, look for your high voltage kind of stuff. We can do your Sokolow-Lion criteria or something like that.
Yeah, there's like 55 criteria or some high number for LVH, but him and I, I'm working in cardiology and inpatient and ER, right? And he's working all over too, and both of us use that. There's no reason to do math if you don't need to. So anyway, now we have a discrepancy of his ejection fraction. What do we do with that as a provider? So here's the secret, okay? Echo is always going to be the one that we're going to defer to. Echo is always correct. But now we have to decide also how to protect our patient from stroke. So there's a score. And Matt, do you want to talk about the risk stratification score? You made a beautiful graphic to illustrate what we're about to talk about.
Yes. Are you talking about your CHADSVASc?
Absolutely.
All right, we'll see if we can put that up real quick. But anyways, the CHADSVASc score is used to determine whether you want to start anticoagulation on someone. It gives you, I believe it's out of 9, and you have there it is. So you have a very scoring and stuff like that. You're going to notice that the only one you have 2 scores for is if you had a history of a stroke or a TIA. Or if your age is 75 or older. Other than that, you guys can kind of read that. It's CHADSVASc. The only thing that was really confusing to me when I first learned about it back in the day was the SC. That just means sex category, and it's female. Females sometimes get a 1. And you can look at it and you can add up the score. And low risk for males is 0, and for females, because they're female and it's the criteria on there, it's a 1. And usually that means no anticoagulation is needed. A moderate risk is male is going to have a score of 1. Females is going to be a 2. And that means it's kind of up to the provider and up to the patient. If they're older and they have a lot of cardiovascular risks, you can consider it as well. And then obviously 2 or more in male, you should probably start some kind of anticoagulant therapy. And then 3 or more in female, you should probably use some anticoagulant therapy as well, such as DOACs or something like that. But I'm sure Jen's going to get into that a little bit more.
Yeah, let's talk about that. So getting into therapy, there's a critical conversation that's going to happen when you're, as a provider, diagnosing an AFib patient. And that conversation, you just need to plan. It's going to be an extended duration, because what you have to do is basically educate them on the risks and benefits of therapy. And yeah, there is a possibility that sex may be removed. And there's also in the guidelines, just speaking of EKG Master's great comment there is some recommendations of using other criteria as well as CHADSVASc to make the full decision. But essentially, once you've determined they're at risk, then you have to pick an anticoagulant and then ask the patient if they're okay with proceeding. So you're of course going to do that other score. We don't have a graphic for it, but it's called the HAS-BLED score, because you need to make sure that they're not too at risk for bleeding. But then once you've cleared them from that, you've looked at their renal function, you've made sure they don't have any active bleeding, that they don't have any contraindications, they're not falling, then you can consider an anticoagulant. But the other thing you're also considering, and I will come back to that piece, is you're considering other therapies. For example, getting them out of AFib. And it's interesting because for some reason, and you and I both follow Dr. Amalmatu, Matt, right? He has this great saying that AFib begets more AFib. And it's really true, because there's something interesting that happens mechanically behind the scenes for the heart, where once the heart gets a taste of it, it wants to go back in it. So the goal of the guidelines and of every electrophysiologist that I've ever worked with is to get them out of AFib as soon as possible. And a lot of times that means ablation, which is why it's gone up in the guidelines. The other thing that's gone up in the guidelines as a higher recommendation is doing something like a Watchman. Now, Watchmans are great for the right patient, and I really love these devices because they allow patients to come off anticoagulation, and especially if they're falling and they are high risk or they're having GI bleeds, then we don't want to leave them unprotected, right? So that is another option. But first line is still going to be anticoagulation. So as Matt said, you're going to consider a DOAC, right? A direct oral anticoagulant. And I'm going to run through a couple of those because we all know the players, but I want to give you some tidbits on the players really quick. And then I'll turn it back over to you, Matt. But number one, I'm just going to say I have no financial interest in any company, but I do notice that most providers do gravitate towards Eliquis, and I do too. And the reason why, it has a good safety profile, very easily tolerated, and it's just safe. And it really does the job. It gives you that 24-hour protection. There's also Xarelto, which is preferred by patients because it's QD. And oftentimes if providers can't get Eliquis covered, they will try Xarelto because it does have a coupon card, which can help the patients get a significant discount, which is very beneficial. And then if you go back in time, there was Pradaxa, and then you also have, more recently, you have Savesa. You're probably not hearing about Savesa very much because it's not used. You have to have a GFR of 90 for it to be therapeutic, which who wants to monitor that every 5 minutes? And that's why you're not seeing it prescribed pretty much ever. And Pradaxa is something that is still prescribed sometimes because patients, if they want to have a guarantee of a reversal agent, they'll often choose Pradaxa, which uses Praxbind, which even if you're traveling, you'll usually have access to Praxbind at a hospital. Now, there are reversal agents. This will be my last thought before I punt it back to you, Matt. There are reversal agents for Xarelto and Eliquis called Andexxa, but unfortunately it's very expensive, like $12,000 a dose, and not all centers have it. So patients need to know that before we help them make an educated decision on what anticoagulant to choose. And of course there's Coumadin, but that's falling kind of out of favor now, unless they have severe renal dysfunction and they're on dialysis. So Matt, I'm going to turn it back over to you.
Yes, well, I thought you made an excellent case about, when patients are starting in AFib, you want to kind of convert them because they learn, your body and heart just learn to stay in it. The longer that you're in it, the more remodeling that happens and stuff like that, and tissue heterogeneity that happens, to the fact that where you just become persistent or even permanent AFib, and you don't want those kinds of patients. I'd like to say that educating your patients and stuff like that is one of the hardest things that you can do, but it's also one of the most important things to do. So CardioVisual actually has an app that you can use to help break down various types of medical or cardiac related issues to your patients and give them videos and stuff like that. And another thing that I totally forgot to even talk about, but the Apple Watch, your patients, a lot of patients now have these Apple Watches. I don't, because I just can't have it. But regardless.
Can I talk a
Yes.
statement that we had? Okay, this is actually a really great story. So there was a patient who had palpitations. She was in her 60s. She went to the ER. They monitored her. They did the full workup. It was all negative. They never saw anything on the monitor. They discharged her to follow-up cardiology. And when we saw her, I said, oh, well, can I take a look at, were you wearing the watch at the time of your palpitations? Yes. I said, okay, let me see your health app. Let's open it up. Let's take a look together. And she had actually had some AFib detection around that time. And we were able to start her on anticoagulation and probably prevent a stroke, which is a great thing. I will tell you that the Apple Watch has a really good accuracy. I don't obviously usually start anticoagulation just off the AFib watch, but obviously we got a Holter and proved it. But I mean, it was such a clear tracing, and you could tell it was an artifact. And I love the quality of the tracings from the Apple Watch. You just have to make sure they have it really close to their skin and the watch band tight. And there's another app you can use, or device you can use, called Kardia, K-A-R-D-I-A. But I tend to think it's not as reliable because the patients have to stay really still. And if there's any movement, there's artifact, and it can give them false readings. So I really like the Apple Watch. And the other thing, just to kind of round out really quick for our seniors, if you're taking care of a senior, especially with AFib, and you're worried about them falling, there is fall detection on an Apple Watch. And it will actually call 911 whether you're conscious or not if it detects a fall, which is so great for anybody who's at risk to fall. So I'm a big fan of technology helping us save our patients.
I agree, and it makes everyone's life a little bit easier, and stuff like that. So I would like to ask, what topics do you guys want to learn about in the future? I would love to have Jen back and have me back here. So yeah, is there any questions that we might have missed? I tried watching, but they sometimes come a little bit quicker than I can read. We got a couple EPs in the VA in Florida.
Nice. Hello, are these watches approved? Yeah, there is. There's articles on it, the accuracy, and you can totally pull them up. You can just Google it. It's easy open source. Hey, thanks, Styled Medics. Good to see you.
All right. CHADSVASc, heart variability relevance.
When I start anticoagulants. So real quick, just to answer that question that I did see float by, and then I think, Matt, someone wants to hear about AVNRT, so it's your specialty. So talking about anticoagulation, when can you start and how long do they have to be on it? Those were two questions. I'll just answer those real quick. So basically, as soon as you see the AFib, it's time. like even in the office, it's time to start the anticoagulant. And I know that a lot of, if there's primary care folks watching, I know there's a lot of hesitation because primary care generally doesn't feel comfortable with starting anticoagulants. And it's just because it seems to be out of your wheelhouse, but I just want to plant the seed, whether, no matter where you're working, start them where you're working, because it's not just cardiology's responsibility. If they're waiting for a cardiology appointment and they have a stroke between that time of seeing you and cardiology, it's on you as wherever you were seeing them. If they're safe drugs, you just have to know the dosages and know the contraindications. And then as far as do they get an ablation, here's the thing, okay? A lot of, if you read the guidelines, they don't want us to take people off of anticoagulants. And here's why. Even if you've ablated them, if they have a high CHADSVASc, because, well, first of all, there's going to be a 3-month blanking period after an ablation where we know they're going to have atrial fibrillation. And so we expect it. We're going to keep them on for that 3-month blanking period. Some electrophysiologists will take them off of anticoagulation after that if they have a risk-benefit discussion. But here's the reality and what's really happening. And you see this when you do the follow-up Holter monitors or Zio patches, which are also great tools to detect AFib. And when you're looking at those, you're realizing that AFib has a high recurrence rate. And here's why. Yes, we may ablate, but there's other things that are still going on in the background of the patient. For example, they're not addressing their sleep apnea, or they're still drinking alcohol, which is unfortunately just lights a fire in the heart, or anything inflammatory, even dehydration or not treating your sleep apnea or electrolyte disturbances can put you into a flare of AFib. So they recommend we just don't take them off anticoagulation. So anyway, back to you, Matt. I think there was a question about AVNRT.
Yes, so I saw there's even stuff about Swan-Ganz and balloon pumps and stuff like that. Probably gonna see something about like Impellas or something like that in there, but maybe another talk. Probably not this talk. A little off topic. But anyways, AVNRT and AVRT are supraventricular tachycardias. They're very regular. They're very difficult to kind of discern between one. The AVNRT is a re-entrance circuit that goes round and round and round in your AV node. And that's all it is. And your AV node has like this fast and slow track and stuff like that. There's like one ways where you can measure the RP and see if it's a short RP or a long RP. Atrioventricular reentry tachycardia. So there's a connection between the atria and the ventricles, and it creates this reentry circuit. Once again, you can have an orthodromic and antidromic. Orthodromic looks like your typical SVT. Your antidromic can actually look like your ventricular tachycardias. It's something that you can see in your patients with Wolff-Parkinson-White because of the accessory pathway, such as the Bendel-LeKent. And you kind of just treat it like your normal kind of SVTs if they're unstable, synchronized electrical cardioversion, stuff like that. But hopefully that kind of answers it. AVNRT and AVRT are just are very broad, and they could take a lot of time to talk about. But maybe that's something we can actually get into a little bit more. It's very interesting types of pathologies.
One of Matt's favorite things.
Yes. I love WPW.
Oh, you know what? Speaking of WPW, Matt, we should tell them about, because it relates to AFib, one of the risks of not treating Wolff-Parkinson's White is that you can go into AFib with RVR. And when you have a young patient who's in AFib with RVR, I always add that to my differentials. Is there an underlying Wolff-Parkinson's White? And it's interesting. I know, Matt, you have a ton of great graphics on, there's a unicorn graphic you have to help us sort out Wolff-Parkinson's White. But, the key with Wolff-Parkinson's White, and I'm going to answer this question that hasn't been asked because a lot of people ask this. Matt, I know you get this too, is unfortunately, the patients, he'll say, hey, do I have a delta wave in just this lead or over here? And you have to have it in more than one lead. So delta waves are really elusive. And it's funny because I was teaching actually an 8-year-old how to read rhythms, which I know it sounds crazy. She was like this nerdy little cute 8-year-old. So I just loved her. So there was this game, right? This arrhythmia game. And I was like, they had WPW, and she called it the eyebrow rhythm. So it looked like an eyebrow to her. So it's like, whatever it looks like to you, good. Use that, but identify it. And you will see it in more than one lead because it's a 12 lead, right? You're looking at the same heart in just 12 different views. And I know, Matt, you have some amazing graphics on that if people want to check you out.
Yes, I do have have a lot. AFib with WPW is a very, very interesting thing. I see someone here had WPW. That's yeah, that's that's really cool. One of my friends actually has WPW as well. It's a very interesting kind of, like I said, pathology. So I'm seeing stuff as rapid AFib, the same as RVR. Yeah, it's just fast AFib, rapid ventricular rate, rapid ventricular response. It's just medical people, for some reason, just like to overcomplicate things and use big words,
Yes, we
you
do.
know, for no
Yeah,
reason.
why make it easy, you know? So there's a couple other questions. I'm just gonna chime in on those real quick. Is AFib more hereditary or lifestyle? So it's definitely lifestyle, 100%. And you can definitely reverse it or get rid of it with really doing all the things, all the prevention. What about those who get paroxysmal AFib? Yeah, so paroxysmal still needs anticoagulation. That's a good question. Some people will, there's some people who just don't want to take anticoagulation if they have paroxysmal, and they'll do the pill in the pocket approach with an antiarrhythmic drug. But I honestly don't recommend that, because here's the thing. First of all, not all people feel their AFib, which was a surprise to me. And then the other thing is, if you're sleeping, you don't know you're in AFib, or even if you do feel it, you could have a stroke in your sleep. So I don't recommend just taking it once in a while. There's also some approaches that I've seen providers take where they'll give the drug, the anticoagulant, only when you feel AFib, but that's just not a good strategy. If you're going to use pill in the pocket, a lot of times they're using it for rhythm control when somebody goes into AFib, paroxysmal, to try to get them out of it. So antiarrhythmic drugs, it looks like there's a question about that. So basically, wanted to say a quick thing about antiarrhythmic drugs. You have to choose the right drug, right? If they're in heart failure, you can only use certain drugs. If they have coronary artery disease, you can only use certain drugs. And the myth about antiarrhythmic drugs is that they fix the problem. They're not really fixing it. It's still there, right? It's still the substrate that's happening. And they're also proarrhythmic. In fact, a little side note on that, there's sotalol we often use, and there's amiodarone. Now, if we're starting, there's also Ticasin. So if you're starting someone on sotalol, even though it only prolongs the QT 40 milliseconds versus the amiodarone, which prolongs it 80 milliseconds, there's actually more episodes of torsades de pointes, one of Matt's favorite rhythms as well. There's more episodes of that on sotalol, even though there's less QT prolongation. So talking about that real quick, know that all your antiarrhythmic drugs have a risk of that. So really monitoring your QT is super, super important.
Absolutely. And I know another medication that you can give is, I believe, flecainide. But with flecainide, you got to make sure you start some kind of, such as beta blocker or something like that, along with it, because you don't want something to happen, one-to-one atrial flutter.
That's such a good point, because not a lot of people know that, Matt. I'm so glad you brought that up. And Catherine just said Ticasin is our drug of choice. Ticasin I love too, Catherine. But what I don't love about Ticasin, I don't love when the patients are hospitalized for 3 days to start Ticasin, and you have to do their EKGs like 30 minutes after their dosing, and you have to watch their QT like a hawk, because also the patients, when they do that, they're not super happy when you go see them. They're like, why am I here? And they're twiddling their thumbs, right? But so that's a frustrating thing from a patient standpoint. But honestly, I love that drug too. Oh, okay. Let me talk about this. Magnesium. I just heard that. Okay.
Yes.
So you guys know, Matt's like, oh, here she goes on the magnesium. But magnesium is a great cellular stabilizing thing you can use. And it also is really beneficial for people with PACs, with PVCs, for symptom relief. And also, you can't use it if they have diarrhea or decreased renal function, right? But you can use it in almost every patient. And it also helps anxiety. It can help restless leg. Magnesium helps a lot of things. So it's always my go-to if they don't have any contraindications, 100%. One, I love magnesium so much. So and it also helps reduce blood pressure as well, magnesium. So there's lots of different flavors of it as well. People always ask that. So I'm a big fan of magnesium taurate, T-A-U-R-A-T, for being cardio specific, but I just would avoid, yeah, Calm is good actually. Somebody just recommended Calm, but I would avoid using like citrate, because that's what's in that you give patients for constipation, and they will not like you. They will not be fans.
Patient
Okay.
satisfaction.
Yeah, it's
Yes,
huge, right? We have to.
absolutely.
Yeah. Oh, yeah. Do you want to talk about paroxysmal, Matt? What it is, the definition of it?
Yeah, I can absolutely do that. So your paroxysmal is your is is your AFib that lasts between 0 and 7 days. It usually self-terminates on its own, and yeah, then there's three main kind of ones. There's your paroxysmal, your persistent, which lasts greater than 7 days up to about a year, and then you can get into something called permanent AFib. That's usually joint decision making between the patient and the provider, saying, "Hey, we're not going to elect to try to convert this back to a normal sinus rhythm anymore." Sometimes with those patients, they can do like an AV ablation and do like ventricular wires and a ventricular pacemaker in there. But that's usually like the very
Oh,
last
yeah. That's
thing that you
so
want to do.
wrong.
That's very far down the line.
End of line, AK-47.
Yes.
But we do go there sometimes. And we go there, Matt, when we've tried, that's what we do, like when we've tried everything and nothing works and they're still symptomatic, or maybe they're dropping their EF, then we'll often do that. And then if they have a left bundle and they have a depressed ejection fraction, they can be a candidate for the CRT, which has the 3 wires.
Yes.
And can actually improve their EF. So ablation is indicated in those patients with reduced ejection fraction, really high up in the guidelines. And then of course, CRT if they have the left bundle and decrease ejection fraction.
Someone's asking, how often do we guys do this? Hopefully more often. We'll see. It's in your hands at the end of
Yes.
the day. How much do you guys like Jen and I?
Yeah. Type in the comments and then we'll come back and see you for sure. Left bundle leads are available now too. See, Catherine, super smart.
Yes.
Yeah. I'm gonna keep my eye on you, Catherine.
You don't want to call us that ventricular dyssynchrony is, I guess, what
Yes.
they're trying to do.
100%. Do you want to talk about the heart creating its own pathway? Every week. Somebody said, can the heart create its own pathway?
As in,
Yeah, I don't think I've heard of that. The only thing I would say would remind me of that would be if somebody has WPW.
yeah.
That's your body having an accessory pathway that doesn't belong. An interesting fact about WPW and ablation, which is one of the things we do to correct it. Well, actually, it's the thing we do. Sometimes people can actually go back in it, even though they've had an ablation. I've seen that twice. And I don't know if the mechanism behind it, but sometimes it just regrows, or maybe there was a dormant tract that came alive and sprouted that needs to be ablated again. So it's rare, right? It's rare. SVT ablations are similar. Usually it's a one and done, but AFib ablations are not a one and done. A lot of times. We hope they are. But here's the thing. If you go into an AFib ablation and you have permanent AFib, like Matt was defining, like we've kind of given up on restoring sinus and we've tried everything. They have a really low first-time success rate. It's like 60 to 70, maybe not even that high. But if they're a first time out of the gate paroxysmal, we've caught them early, they didn't have a lot of chance to remodel, their atria is not super enlarged, then a lot of times we can actually just do it with one and they don't need a touch-up. It also depends on the kind of procedure they do, which I'm sure Catherine knows all about. But yeah, so sometimes a third too, we hope not, but it's possible. We don't usually go over 3. We don't like to, because that's a bunch of tissue that you're either freezing or burning depending on the procedure used.
Yeah, and ablations at the end of the day are you're scarring that heart tissue, and there's you can do like pulmonary vein isolation, and certain types of AFibs and stuff like that. And at the end of the day, the more ablations that you're doing, you are scarring that myocardium, and it's you don't want to cause that. Yeah.
So someone asked if we're both cardiologists. So I'm actually a cardiology PA of 17 years. Also have worked in the emergency department almost my whole career as well, and formerly for 13 years a paramedic. And Matt?
I'm currently a paramedic and also in PA school. I have this deep love for cardiology. My mom, interestingly enough, has a rare congenital heart disease called anomalous left coronary artery from the pulmonary artery, or ALCAPA for short. And that's what got me really kickstarted. I think it was back in high school, which was way too long ago. I don't want to say how long. That'll make me a little sad. But no, I've always had this deep passion for cardiology. My mom's been a PA. She did ER and cardiology as well, and like that's where I want to go, is a little cardiac ICU or inpatient cardiology, something like that. Maybe even pediatric cardiology.
Yeah, I could definitely see that. He's asking if you've heard of the Ross procedure.
I have not.
I haven't either, so maybe Catherine might be able to tune in on that one. Allison says, we're grateful for you both. Allison, we're grateful for you too. Thank you for tuning in. Let's see.
Doing some Googling on the
Okay,
Ross
yeah,
procedure.
he works in the medical ICU, CCU. So,
Okay,
yeah.
very nice.
Yeah, I think mostly we're just talking about outpatient AFib strategy. And so if you guys have any more questions, drop them in the chat. We'd love to answer them. We're really super exciting to be here with you. Just, hold on, Matt, hold that thought. Somebody's talking about fish oil. I gotta go there. Sorry, I gotta go there. You know, Matt, it's like magnesium and fish oil are my jam. Okay, so fish oil, here's the thing. I love fish oil. I'm a super fan, okay? But unfortunately, there is new evidence that says fish oil can lead to AFib. I'm not really sure that it's causative, to be honest with you. The jury's still out for me personally, but I still do not go over 2 grams of fish oil a day for people. The other thing about fish oil, you guys, you cannot let patients go to Costco and get fish oil. You don't know what's in it. Bad idea. If you're going to get fish oil, we prefer that you get the pharmaceutical grade, Vascepa, something of that nature. But worst case scenario, and again, I have no product interest in this, but there's a fish oil that I trust that's called Nordic Naturals. You can even get it on Amazon, but it's actually made in California, in Watsonville, and it's a safe one. But the other trick with this, and a lot of people don't know this, is a lot of people have fish oil burps, especially with the bad fish oils. But if you take the Nordic Naturals, or you can put them in the freezer, and then there's no fishy burps or aftertaste. So anyway, okay, going back to Matt, final thoughts, wrapping it up. I'm going to promise not to get enticed by any more fish oil or magnesium. But any final thoughts for people who are new, Matt, who are like, gosh, how can I know as much as you, Matt, on EKGs or all this stuff? What would you tell them?
How to get good? I'm not good. I just enjoy looking at squiggles a lot. And I like to make people can overcomplicate things and all that kind of stuff. What I learned is I kind of self-taught, and I shot myself in the foot. It took me a long time. At the end of the day, Jen has a really great EKG class that's free on Facebook. You guys can check out. It's really wonderful. I actually teach over there as well. So
Yeah.
fun stuff. But at the end of the day, it's just repetition and it's pattern recognition. So the more patterns you see, the quicker and easier it is. When I first looked at 12 leads, I tell you, here's a blank piece of paper. I'd be like, lead one. It would take me probably 3 minutes to fully 3 to 5 minutes just interpreting it. It was a little embarrassing when I was brand new. But as time comes on, you get better and better and better. Do you have any tips, Jen?
Yeah, I think the same as you is pattern recognition and practice. People are always like looking for the shortcut on learning EKGs, but there really isn't one. You just got to put in the reps. That's what I tell people. There's one other patient question, real quick. We can't give medical advice, but we can. There's someone that says, I've been having AFib for 5 years. I'm on a med, no AFib as long as I take the med. Do you think I must go for ablation? So there is never any musts, but just know that it's a discussion to have earlier in your course before you become permanent with your cardiologist, your electrophysiologist. Hopefully you're seeing an electrophysiologist and not just a general. And here's why. The electrophysiologists are very well versed in the risks and benefits of the procedure, and they can educate you. But a lot of people do just decide to be on the medications, antiarrhythmics, or beta blockers or calcium channel blockers for rate control. And it's all dependent on the symptoms that you have and how much they bother you and how much risk you want to take for potentially getting rid of it. But it is pretty safe as a procedure. It's very effective, especially if you catch it early, which is why the electrophysiologists are always like, Please refer early. Like if there's any primary care or just urgent care, ER, anything on here with us that you work in like a clinic, just know that the earlier you refer to electrophysiology, the sooner they can potentially fix it and help your patient long term. Because AFib does remodel your heart in a negative fashion over time. So that's my recommendation for any new providers. Okay, so
Someone was asking about your information for your
yeah,
Facebook information. So it's the 3-day EKG challenge on Facebook.
yeah. If you want to see more of Matt in there, there's if you go under bonus, if you get in the group and you go under bonus sessions, under Sunday Stories, Matt does a bunch of classes in there, which are really cool. We always love having Matt around.
All right.
All right, I think that's about it for the night. I think we answered most of the questions.
I think we did a pretty good job. All right. Well,
Sweet.
thank you so much, guys. It was an absolute blast to spend a little bit of time with you guys. I know we went a little over, so I apologize. But, thank you guys for coming out today.
And CardioVisuals, thank you for having Matt and I, but mostly my co-host with the most, Matt. It's always an honor sharing any stage with you.
It's my pleasure as well. It's always so much fun.
Good night, everybody.
Good night, everyone.